So good afternoon, everyone, and welcome to Mito Action's monthly expert series. Today, we will focus on finding the sweet spot, diagnosis and management of diabetes and hypoglycemia in individuals with mitochondrial disorders. My name is Stephanie Harry, and I'm one of the patient support coordinators here at Mito Action and will be your host for today. Today's presentation will be recorded and available on Mito Action's website in the coming days, as well as on our podcast, Apple Podcast, Google Play, and Spotify. We encourage you to ask questions throughout the presentation using the Q&A feature on the bottom menu bar of your screen. You can also use the chat. If you are calling in via phone, feel free to submit your questions to us by email at info@mitoaction.org. We will do our best to get through as many questions as possible at the end of today's presentation. Individuals with mitochondrial disorders are at an increased risk of developing both high blood sugars, diabetes mellitus, and low blood sugars, hypoglycemia. Today, Dr. Shanna McCormick will review considerations for diagnosis and management of these conditions and touch on related endocrine problems, including growth problems and adrenal insufficiency. Our goal is for individuals and families to be well informed for future discussions of these endocrine issues with their clinical care teams. We're absolutely excited and ecstatic to have you here today, Dr. McCormick, joining us, and we're really excited. This is such an important conversation. I'm going to share Dr. McCormick's bio real quick. She is an attending physician at the Division of Endocrinology and Diabetes and is an assistant professor of pediatrics at Perelman School of Medicine at the University of Pennsylvania. She cares for children with pediatric endocrine disease and has a clinical interest in patients with endocrine dysfunction related to rare metabolic disorders such as primary mitochondrial disease, Friedreich ataxia, and lipodystrophy. She also has an interest in inherited and acquired forms of hypothalamic and pituitary dysfunction, in particular those associated with abnormal energy balance and obesity. As a physician scientist, she investigates the neuroendocrine systems that regulate energy balance in humans. Her translational research program has two main areas of focus. First, she studies individuals with metabolic disorders characterized by risk for diabetes, including primary mitochondrial diseases, Friedreich's ataxia, and lipodystrophy. Second, she focuses on brain disorders associated with excess weight gain, including brain tumor-related hypothalamic obesity syndrome and pseudotumor Seabry syndrome, idiopathic intracranial hypertension. She also performs detailed assessments of mitochondrial bioenergetics and metabolism. So again, we are so lucky to have you here today, and thank you for joining us, and we are eager to learn.
Super. Thank you so much for that kind welcome and that introduction, and even more important for the opportunity to speak, because I learned so much in preparing for these sessions and from the really terrific questions that follow. So thank you again. Just to confirm, Stephanie, can you see my slides okay? Yes, I got the thumbs up. Wonderful, wonderful. And I'm really appreciative of all the folks who are joining us and the folks who may be listening afterwards. So Stephanie gave a really kind introduction and an overview of what we're going to be discussing. And she and I were speaking before the rest of the group came on. And so I'm reminded to make two quick comments, two quick caveats. One is, I'm talking about my experience here about mitochondrial disorders, but as I imagine members of the audience, because you've come to this seminar, there are differences between individuals with different kinds of mitochondrial disorders, and even within a given mitochondrial disorder or individual families with a given genetic mutation, for example, everybody is different. So I'm hoping that you'll take some of the comments that I make today not as gospel per se, but as a starting point for a more informed discussion with your care team and give you some ideas to help either you or your loved one feel and function better. And then the second caveat, I am a pediatric subspecialist. I work very closely with our adult colleagues, and a lot of our research studies include both children and adults. And my predominant experience is in children. So I'll do my best to highlight pediatric specific considerations where that's relevant. So I'm thanking the members of the Mitochondrial Frontier program. There are many more than are listed here, but in particular, Amy Goldstein and Marnie Falk at CHOP, some of you may know them, with whom I collaborate both clinically and research-wise, because they teach me so much every day, and without whom I couldn't do this. And of course, my terrific patients who teach me the most. So this group knows, because you've come to this seminar, that mitochondrial disorders impact endocrine function in many ways. So many different endocrine disorders have been associated with primary mitochondrial disease. In fact, you see them, the endocrine manifestations listed in this schematic here: short stature, hypoparathyroidism, which is problems with calcium, adrenal insufficiency, which is problems with production of those adrenal hormones, diabetes, which is one of the research focuses of mine, difficulties with gonadal steroids, meaning with reproductive hormones, and of course, pregnancy-related complications. So in fact, it would probably be challenging to find, or just think of, an endocrine, a hormone problem that is not affected by mitochondrial disorders. So the one thing to remember about endocrinology, and is one of the reasons I went into it, is that many endocrine disorders have treatments. So whereas some specific genetic mitochondrial disorders don't, unfortunately, at the moment have FDA-approved therapies, their endocrine complications may have treatments that, although they're not perfect, could substantially improve quality of life and health. So to my mind, it's important to find endocrinopathies, endocrine hormone problems, if they're there, because we can help people feel and function better. Another point to make, and this is highlighted to some extent on this schematic, is that we're learning more and more that certain subtypes of mitochondrial disorders have increased chances of endocrine disease. So you can see that, for example, and Stephanie and I were speaking before we came on, individuals with single large-scale mitochondrial DNA deletions tend to have a relatively higher burden of endocrine problems. So examples like adrenal problems are problems with calcium regulation. There are individuals with the 32438 A G and other mitochondrial DNA variants have excess risks for diabetes. And in contrast, short stature or less than optimal growth is much more common and occurs across a large range of genetic conditions. We've seen individuals with certain specific disorders that affect their ability to go through puberty or achieve reproductive outcomes. So understanding in the context with your clinical team what particular endocrine disorders for which you might be at most risk is also potentially interesting. So when I was asked to present today, I thought I could try to talk about every organ system, and I have in the past, and that's really tough to do. We can certainly, in the question and answer, get to some of what I'm not going to cover today if you have an interest. But I thought focusing on blood sugar would be helpful for a few reasons. One is it's what I encounter most often, and it's pretty common. Also, it touches on a range of additional hormone problems that influence blood sugar. So it's a nice focus to allow me a chance to talk about more than one thing. And I see that the questions accumulating in Q&A, which is awesome. Please keep them coming, because I look forward to the discussion that we're going to have at the end of my around 30 or so slides. So first, I'm going to talk about diabetes and hypoglycemia. So diabetes when the blood sugar is too high, hypoglycemia when the blood sugar is too low. I know we have a really sophisticated group. I'm going to do my best to keep my language free of jargon, so that we can also keep the talk accessible for folks who may be newly diagnosed or new to these conditions. But please interrupt as well if any of the terminology is not familiar. We're going to talk about adrenal insufficiency, which is lack of the hormones cortisol and sometimes aldosterone that affect various functions, including blood sugar and fluid balance. We're going to talk about growth. And we're going to talk, there's a lot that we're not going to talk about, but we can if folks have an interest in the Q&A. So calcium homeostasis, bone health, thyroid function, energy balance, so too much weight gain, too little weight gain, and hypogonadism, which is insufficiency of the reproductive hormones like estrogen and testosterone. So we know that endocrine problems and mitochondrial disease are prevalent and treatable, not only from our clinics, but because some people have put together these data. And I was lucky enough to have access to data. Many of you may participate in some of the natural history studies, and for those of you who have elected to do that, we really thank you, because it helps us learn and put together projects like this one. So Iman Al-Ghadi, who was a fellow at the time and is now a pediatric endocrinologist, took data from the North American Mitochondrial Disease Consortium and examined 400 individuals who had molecular diagnosis of mitochondrial disorders, and then did some calculations, like what are the endocrine problems that are observed most often. And the single most common problem was atypical growth and pubertal development. So most often not growing as quickly as we might expect, or going through delays, or sometimes earlier puberty onset. Diabetes was common, relatively common in this cohort, and problems with thyroid hormone were also reasonably common. Other endocrine diagnoses, information about those weren't really collected systematically. In other words, they weren't part of the questionnaire, because this was a study designed to look at all kinds of complications. So it didn't include some of these details that are most relevant to us as endocrinologists. But low blood sugar is problematic, as is adrenal insufficiency, hypoparathyroidism, and problems with bone health. And we have one of our fellows who Herodes Guzman, who's fantastic, who's going to be doing an endocrine fellowship and a genetics metabolism fellowship, who's going to be taking up some of this research next. So I'm really going to be excited to present in future what Herodes works on to follow up on this great study. So thinking about glucose homeostasis, this is a diagram that I make that I'm going to take you through, because it helps, maybe it helps you see how I conceive of the challenges related to blood sugar in folks with mitochondrial disorder. So here on this x-axis is nutrient availability, meaning like how much nutrition is available. So is there limited nutrient availability, like when someone is fasting and not eating, like some kids are asked to fast before an operative procedure, for example? Or is there excess nutrition when some kids, for example, may be getting tube feeds, which are kind of calculated based on what their posited requirements might be, but for any given individual may be more or less than they need. So, some folks are given more nutrition than they need. Some folks may be given less in different circumstances. And then what happens with blood sugar, right? So for anyone, if there's too much nutrient, blood sugar is more at risk to go high. This is individuals, who are healthy here in green, and individuals with metabolic disorders in red. With anyone who gets too much nutrition, blood sugars can go up, but the tendency to do that can be higher in folks with mitochondrial metabolic disorders. Similarly, in the nutrient limited circumstance, like many folks who are otherwise healthy can fast overnight or even longer without much difficulty, but in folks with mitochondrial metabolic disease, their blood sugar tolerance for fasting is less. So this is where the title of the talk comes from, the sweet spot, finding the sweet spot, like where is the right blood sugar, where's the right nutrient range. The sweet spot, or getting to the right place, seems to be narrower in folks with diseases. In other words, families often resonates, like keeping folks in their good range is possible, but it can be easier to be kind of disrupted from that typical range than it might be in a healthy individual. So our goal is to keep people here in that nice good range, and that can be tricky sometimes, but hopefully we'll give you some strategies. So thinking about diabetes, this is a basic review, and some of these symptoms that this comes from the UK, the National Health Service has an educational campaign to teach people about diabetes. This is in all comers, in all individuals. So the way an individual with mitochondrial disease might manifest high blood sugars could be a little different, but they also might share symptoms with folks without mitochondrial problems. So excess thirst and urination, this happens because when blood sugar exceeds around 180 or 200 milligrams per deciliter in anyone, it exceeds the capacity for the kidney to reclaim that sugar from the urine. So when the blood sugar is 200, 300, it spills into the urine and it pulls more volume from the blood with it. So people pee and pee and pee and pee. And as a result of all that peeing, they're thirsty. As a result of all that peeing too, there can be fatigue and unintentional weight loss related to both dehydration and loss of the sugar into the urine. Now, people with mitochondrial disorders whose kidney function may not be typical may spill glucose into the urine at even lower blood sugars. So for example, if for someone without mitochondrial disease, we don't see sugar in the urine until the blood sugar is like 200. Someone with mitochondrial disorder, the glucose might spill into the urine at a lower blood sugar, like 150 or 140. So these symptoms could develop even lower. Really, the educational point that I make with my patients is if you have a mitochondrial disease that predisposes to blood sugar problems, then blood sugar problems should be on the list of things to check if a person is different from their baseline, which I acknowledge can be challenging in folks whose baselines may fluctuate. So this is an example of a case, and the cases I'm presenting today, I've changed some of the details just to protect folks' privacy, but they represent an amalgam of the cases of that we take care of here at CHOP, or cases that I've heard of from colleagues at other institutions. So this is an example of a little girl with a single large-scale mitochondrial DNA deletion syndrome. Dr. Goldstein says like SLIMDIS. I don't know if I love that acronym or not, but that's what it is. This little girl had multiple endocrinopathies. So at 4 years old was diagnosed with hypoparathyroidism. That's the problem in regulating calcium balance. At 8 years old had come to attention for evaluation of short stature. So I'm showing you here her height and BMI curves that you may see when you take your child to the pediatrician. So on the x-axis here is age in years, and on the y-axis here is height, and here is body mass index. So you can see that height, was on the lowest part of the curve and then kind of fell off the curve enough by age 8 that this child was evaluated for short stature. And then at 10 years old, they were diagnosed with mitochondrial diabetes. And if you look over here at the BMI curve, you'll notice that it was low and got lower. Body mass index is weight kind of indexed to height. So we see how much does someone weigh relative to how tall they are. Taller people should weigh more. This child's weight relative to her height was falling off. So what happened here, I imagine members of our audience could guess, what happened here was that a gastrostomy tube was placed so this child could be better nourished. And that was absolutely the appropriate clinical decision for this child, who was really struggling with low energy and with frequent illness when she wasn't able to stay nourished. But one potential consequence of G-tube placement, and something for which we prepared this family, was that now with increased nutrition, which absolutely was appropriate, the child's pancreas that was really not able to make a whole lot of insulin to deal with that increased nutrition could manifest diabetes. And sure enough, that's what happened. I'm mentioning that here because one of the kind of takeaways I wanted for folks is that we try to set up our patients to know there are certain circumstances like G-tube placement, like illness, like growth hormone initiation, like high dose steroids that predispose to higher blood sugars. And if we know that, and if we monitor blood sugars in the course of those interventions, then if we see any high blood sugars develop, we can catch that early and help the patient stay safe. So that's what happened in this individual, was when blood sugars were higher, then insulin therapy was started to help keep blood sugars safe. This individual has many of the other health problems associated with single large-scale mitochondrial DNA deletion, including from an endocrine standpoint, or what affects endocrine function, pancreatic problems for which enzyme therapy is required, kidney problems, which affects the metabolism of certain diabetes medications, and heart block, which affects the risk for heart rhythm problems with electrolyte abnormalities that can accompany diabetes. So when I think of mitochondrial diabetes, people often ask, like, is mitochondrial diabetes type 1 or type 2? And by the end of this slide, I'm going to answer that question. Mitochondrial diabetes, you saw the slide from our trainee, is, present depending on the cohort that you look in, 10%, 20%, maybe more. But I think of diabetes as kind of the tip of the iceberg in abnormal glucose metabolism in folks with mitochondrial disease. In other words, it's really common to have not normal glucose metabolism, even if only a subset meet criteria for diabetes. So when we think of diabetes broadly construed, This is from the CDC website as of, I think these are data, epidemiology data from 2021, 30 odd million individuals with diabetes and close to 100 million with prediabetes. The way the CDC defines subtypes of diabetes, type 1 is autoimmune, meaning for reasons we don't entirely understand, the immune system gets confused and instead of attacking bacteria and viruses, attacks the body's own organs, in this case, the pancreas that produces insulin, which controls blood sugar. So that's type 1, typically has its onset in childhood, although not always, almost always requires insulin therapy. Type 2 is the more heterogeneous weight and habit related diabetes that often has its onset in adulthood, but we see more and more in adolescence as well. Sometimes can be treated with oral medications or non-insulin injectable medications, but sometimes requires insulin as well. There's gestational diabetes, meaning diabetes that occurs in the context of pregnancy. And then there's other, like genetic forms of diabetes, and other is where I would put mitochondrial diabetes into this basket. So that current framework of diabetes, by the way, doesn't work very well for folks with mitochondrial forms of diabetes, for folks with type 2, even to some extent for folks like type 1. And that's because even within all of these subtypes, there's a lot of heterogeneity. I mean, there's a lot of difference between individuals. And the reason for having a diagnostic label is so that we understand better how to take care of patients. And I think these labels are a start, but sometimes labels limit us as well, meaning once the label is assigned, people stop thinking and don't wonder about how patients may be unique. So when people ask me if diabetes occurs in the context of mitochondrial disease, it could share features, and sometimes it does, with type 1 or type 2. For example, if there were antibodies to insulin producing cells in the pancreas, then it might share some immune features. If it occurred in the context of excess weight gain or inactivity, it might share some features with type 2. But I encourage people to think of mitochondrial diabetes as its own subtype. Now, sometimes when people talk about type 1 versus type 2, what they really mean is like, does this require insulin or not? And we're going to get to insulin in more detail in a few slides. But I encourage folks to think about mitochondrial diabetes as its own subtype of diabetes. And my hope there is that we as endocrinologists will think carefully about, even within mitochondrial disease, what's the cause of abnormal blood sugars? And so how do we be thoughtful about the best way to treat? So another example from our case library, this time a 6-year-old girl who did present with those symptoms that I mentioned to you, excess urination and thirst, and had a random blood sugar of 629. So a random blood sugar above 200 with suggestive symptoms is consistent with diabetes. And by the way, I don't know if we have audience members from abroad, but these are the conventional units that we use in the US, and anyone who needs unit conversion, we can talk afterwards. Hemoglobin A1C at the time of this child's diagnosis was 9.6%. So for folks who may not be familiar, hemoglobin A1C gives us a sense of average blood sugar over the past 3 months. Hemoglobin, which is one of the molecules in red blood cells, gets glycosylated, meaning in an environment where there's lots of sugar, the sugar gloms onto the hemoglobin and it's sticky and it gets kind of sweet. So we look and we see how much sugar is glommed onto the hemoglobin molecules in the red blood cells. And that gives us a sense of how high blood sugar has been over the past 3 months. One important caveat in folks with mitochondrial disorders, particularly mitochondrial DNA deletion syndromes, if, for example, a child who has Pearson's that's transfusion dependent, this hemoglobin A1C measurement does not work well because the red blood cell turnover is not normal. So this is where it's helpful to know, even the screening tools that we use for diabetes, typically in the general population, may work well or may not in certain subpopulations. And there's alternative measures, including things like fructosamine, glycated albumin, other ways of measuring a chronically high blood sugar that don't depend on hemoglobin that may be more appropriate if there are folks with those considerations. So this child fortunately had no ketones at presentation. So ketones are the product of fatty acid oxidation. Some folks with mitochondrial disorders can't produce ketones ketones from fat because that's a feature of their mitochondrial disease. But for folks who can make ketones, ketones are produced when, in the absence of insulin to help facilitate burning carbohydrate, the body burns fatty acids instead, and those ketones accumulate. And that process produces ketones in the context of acid and can make kids really sick with diabetic ketoacidosis. So we were glad for this child that there were no evidence of ketosis. And here there were no anti-pancreatic autoantibodies. So a CHOP, all newly diagnosed patients with diabetes, get anti-pancreatic antibody testing to see, is there evidence of autoimmunity? Is there evidence of kind of classic, typical type 1 diabetes? And like many individuals with mitochondrial disorders, there wasn't. So this child met criteria for starting insulin because she was dehydrated. Her hemoglobin A1C was very high. And we know that in kids in particular with mitochondrial DNA deletions or many other subtypes of mitochondrial disease, the pancreas just isn't able to produce insulin well enough in response to glucose. So we need to help supplement that insulin. This patient had other complications of her condition, as we might expect. And again, this is a DNA patient, deletion patient, current Sayer patient. So by some estimates, like what my mother endocrine colleagues are surprised to learn, that up to 5% of folks with what we think might be typical type 1 or type 2 actually have mitochondrial forms of DNA or diabetes. So it'd be more common in the general population than we think. Mitochondrial DNA deletions, diabetes is common. It can also include in folks with nuclear mutations causing their mitochondrial disease, Pol gamma, RRM2B, OPA1. In difference between children and adults, in children, it tends to be more acute in presentation and suggestive of insulin deficiency. So diabetic ketoacidosis, which is that complication that I mentioned, really high blood sugars in the 600s, as in that case example, dehydration. Those are all suggestions that the pancreas really is just not making enough insulin, and that child needs insulin therapy. In adults, diabetes can come on more slowly. It can be acute, but there's more what we call insulin resistance, meaning maybe the pancreas can work pretty well, but the insulin doesn't work where it's supposed to at the end organs. It can happen at a lower body mass index. So some folks with obesity in the general population get diabetes, but in adults with mitochondrial disorder might happen at a lower body mass index at a younger age. And with respect to the complications that can happen, more complications can accrue in the kidneys and in the nervous system, but less in the retina than garden variety type 2 diabetes. So all of this informs us in how we care for our patients. So this I'm showing you here, the ADA, this is the American Diabetes Association, has this huge book. It's hundreds of pages. It's available online for anyone who wants it. The 2023 has guidelines for the management of diabetes. And I show this slide, not because you're supposed to memorize it, but because this is the schematic that is kind of the distilled version of what most of us use for presumed type 2 diabetes for adults. And I'll save you squinting. There is no category here for mitochondrial diabetes, right? So that's the first point to make, is that most endocrinologists or clinicians come to treatment without a clear rubric, although I'll show you some that have been proposed for mitochondrial diabetes, without a clear rubric that's like mitochondrial specific. So it's important to know that. The second thing that's really exciting is there's, even compared to when I first started fellowship now more than 10 years ago, there's a lot more medicines besides insulin and metformin, which you may have heard of, to manage diabetes. So there's more choices, and I think some of them may be appropriate in mitochondrial disease, but we have to kind of balance risks and benefits. So the first consideration when we are choosing management in individuals is like, do they need insulin? Often that's a real safety consideration. So the rule is, if somebody has diabetic ketoacidosis, they have ketones so high that the patient's acidotic, then they need insulin. If they have blood sugars high enough to cause dehydration and weight loss, they need insulin. They often need insulin, sometimes permanently, sometimes initially when they're having those acute effects, and then we kind of back off a little bit and see how much long-term. I have watch electrolytes here. Insulin initiation is associated with electrolyte shifts. Insulin, for example, puts potassium back into cells. Insulin helps nourish our cells and helps our cells make ATP, which folks may remember is the energy currency in the cell. ATP has 3 phosphates in them. So when we start insulin, there's often a phosphorus deficiency that develops, and folks with mitochondrial disease may have underlying kidney problems or other issues that make them vulnerable to electrolyte abnormalities to begin with. So even when insulin therapy is appropriate, and we always watch electrolytes when we give people insulin, we have to extra carefully watch electrolytes in our patients with mitochondrial disorders, things like potassium and phosphorus in particular, to make sure they stay in balance. Some of these novel drugs, you may have heard of GLP-1 receptor agonists. Everyone's heard of Ozempic, it's made in the news, but these have really been game changers. And some of them may be appropriate in individuals with mitochondrial disorders with appropriate consideration for risks and benefits in the particular individuals. And I have a schematic in a second or two about that. Avoiding lows and avoiding ketones are really important. So folks with mitochondrial diseases may not be able to respond to low blood sugars as easily as those who don't have mitochondrial problems, because the mitochondria are really important for our body's systems of defending against low blood sugars. So that means we have to monitor really closely to try to prevent lows. Sometimes that means we set our blood sugar targets a little bit more generously. When we design our interventions. Also, ketones can make folks really sick. Some people with mitochondrial disease can make them, others cannot. This is an important place to remember. There are 2 ways of monitoring for ketones in folks with diabetes. One is blood measurements, which measures the ketone species beta hydroxybutyrate. The other is urine, which measures acetoacetate. Besides the fact that getting a sick individual to pee into a cup and like measuring it on a stick is like logistically very difficult, I favor the blood measurement because the process of going from beta hydroxybutyrate to acetoacetate, so moving between those 2 ketone species, is dependent on intact mitochondrial function. So relying on urine measurements only can underestimate the degree of ketosis in folks with mitochondrial disorders. So I argue with insurance companies because it's more expensive to get the blood monitoring technology, to use that in folks where we want to do that. Speaking of technology, using technology is great. This is, people remember Nick Jonas from the Super Bowl. Continuous glucose monitors in folks with diabetes are amazing to help monitor blood sugars and really give a clear sense of when blood sugar is on its way up or down. I'm reminded to mention there are solutions for folks with vision or mobility impairment. For example, there are insulin pens where the dialing system has auditory cues. So people who may not be able to see very easily what their dose needs to be can hear it instead. So asking about that to your clinical team if new technologies are needed. Glucagon is the hormone that brings blood sugar up if too much insulin has been given. And then there are a lot of different forms that are easier to administer than the older form, which was like mixing together a liquid and a powder. Now there's an intranasal form, like a squirt into the nose, and premixed forms to make it easier and faster to treat a low. There are automated insulin pump delivery solutions that we do use in our mitochondrial disease patients with good effect. So here's a schematic that I mentioned, talking about treatment options and kind of summarizing what we talked about so far. So insulin secretion, meaning the pancreatic production of insulin, is often affected in mitochondrial disorders. And that's because in order for glucose to signal a pancreatic cell to produce insulin, the pancreatic cell has to make ATP. So it isn't directly glucose to insulin. Glucose has to be produced into ATP, and then that ATP signals the insulin. So you can imagine if mitochondrial ATP production is important, then insulin secretion can often be affected, and it is. Insulin resistance can occur, especially in adults. So we educate about symptoms. You all have already heard about symptoms, and you'll already remember if something is new or different. Blood sugar's on your list of things that are easy to check and to exclude. We screen at least annually or based on symptoms, or if something's happening, like a G-tube is being placed or a new medicine is started. You manage based on physiology and ketones, select medicines based on comorbidities, meaning other health problems, and absolutely make use of technology. So here's a schematic. You know, the ADA 2023 guidance doesn't have one, but there's one, at least a few in the literature, that if individuals have suspected mitochondrial diabetes, we can screen with glucose, A1C. Some folks use glucose tolerance tests. I favor multiple blood sugar measurements in the outpatient setting. And if the screening is positive, the first decision is, does this individual need insulin? Are they have very high blood sugars, ketoacidosis, weight loss, in which case that's appropriate? Or do they have more features of what garden variety type 2, where excess weight gain might be a feature? In which case there are medicines that may be appropriate. We tend to avoid metformin, especially in folks who may have a condition, certainly if there's a personal history of lactic acidosis, or a mutation where that's occurred. But metformin needn't be the main therapy because there are other non-insulin agents to choose from these days. And then, of course, screening for complications is important. So, the other side of high blood sugars is low blood sugars, which can occur from the treatment of the high blood sugars, which is unfortunate when it happens. This is a sign from our resident room on the 5 West at CHOP, which is often but not always keep calm and push D10. So for folks who aren't familiar, D10 is 10% dextrose solution. And I say often but not always because this is one of these places that there are many folks for whom this is appropriate. But for example, PDH variants where folks are managed on a ketogenic diet, you have to really be careful with carbohydrates. So hopefully folks are educated and work with their clinicians about their technique, about their problem to say, if my blood sugar were low, what would be the right move? So the symptoms of low blood sugar can be many, but out of the textbook would be sweaty, being shaky, being pale. Unfortunately, low blood sugars can proceed to seizures and unresponsiveness. And the key would be, of course, that it would be reversible with carbohydrate. If we have people presenting with hypoglycemia in the context of mitochondrial disease, we look for what are the treatable causes, like what was the trigger for this event. Malnutrition can be a common one, cortisol deficiency, adrenal insufficiency, which we'll get to, liver problems, because the liver is an important place to store extra carbohydrate and to make and release and make new carbohydrate. So folks with liver problems can have difficulties with low blood sugar. We try to treat and reverse catabolism. Catabolism is breaking down of our body's energy stores instead of building them up. And as I mentioned, ideally really important to have an emergency plan before, like what do we do for low blood sugar? How do we prevent it? For example, how do we, prepare a child for an operative procedure, without exceeding their usual fasting time? Because if we know if this child usually only fasts for 3 hours, if they fast for 6 hours or 9 hours, then they're much more likely to get low blood sugar. So how can we avoid those circumstances in the first place? In general, when we are seeing people and we're evaluating them for hypoglycemia, we tend to divide. One kind of starting place is ketotic or non-ketotic, meaning does this person who has low blood sugar, we have evidence that they're burning fat for energy? And burning fat for energy, typically, if the mitochondria can do it, involves fatty acid oxidations, and one product of which is ketones. So another way to think about hypoglycemia is, does it happen when the person is fasting, meaning after they haven't eaten for a while, or reactive, meaning right after they've eaten, reflecting often a brisk insulin response to eating. And often fasting hypoglycemia is ketotic and often reactive hypoglycemia is not. But as I mentioned, some individuals with metabolic disorders can't produce ketones. So getting to the flavor of hypoglycemia, is it ketotic? Is it not? Is it fasting? Is it reactive? Will help us think about what could be causing it and then how do we address it. And some people may have more than one kind. This is a study I mentioned briefly that Patrick Hanley, who's one of our former fellows, now is an attending at CHOP Nemours, did. When we have children with hypoglycemia, we really can't figure it out. We do very careful what are called diagnostic fasting studies. And people at this point say, wait, I thought you said that exceeding usual fasting time is not a good idea. And it isn't, but especially people without known, disorders. So some of the patients we've fasted didn't have a genetic diagnosis at the time, and the hypoglycemia kind of led to their mitochondrial disease diagnosis. In a controlled setting, we can fast them for defined periods of time and monitor very closely to see what happens, how quickly does hypoglycemia come on. That gives people some safety guidance as far as how long can fasting occur. And then what's the individual's response to low blood sugar, which tells us a little bit more about where the problem is. So the tricky part about hypoglycemia is sometimes that figuring out why it happens, in some circumstances, not all, requires challenging the patient in a controlled setting a little bit. And in individuals with mitochondrial disorder, not surprising to this group, probably the amount of time they could fast was less, and their ability to produce ketones was also lower. So usually, when we're starting and trying to figure out what do we do with this patient in whom we suspect hypoglycemia, we say, well, start with, we provide them a glucose meter. We often provide them a ketone meter, and we say, let's check blood sugar, of course, if you're having symptoms that are suggestive, and after the longest time that you go, usually without fasting. And our goal blood sugar is usually at least 70, less than 50 is an emergency. We check ketones in the blood, not the urine, for reasons that I mentioned. The blood is often more accurate. And ketones can be trace, or they can be up to high. And then once we have a flavor for what folks are experiencing, that's when we can try to design an intervention. And our management strategies consist of well, how should this person be monitored? How should any lows be rescued? And how do we support them to prevent low blood sugars? And I always have this caveat, I think this group well knows, but really watch out for NPO status. Folks get into trouble being NPO. NPO means nil per os, means nothing by mouth. So when folks have been instructed not to eat before procedures, that's when I've seen them get into trouble. So adrenal insufficiency, switching gears, but not, because it's one potential reason for low blood sugars that we end up evaluating. So this is a schematic of the adrenals, and they produce the steroid hormone cortisol, and mitochondrial are critical for steroid hormone synthesis. So perhaps not surprising that there can be trouble with cortisol in folks with mitochondrial disorders. So symptoms of insufficiency of this cortisol hormone, which is triggered by stressors. So signals in the brain go to the pituitary and to the adrenal gland to produce cortisol. And cortisol helps bring blood sugar up and blood pressure up. So stressors like low blood sugar, low blood pressure should, in an intact signaling system, lead to the production of cortisol, especially with critical illness. So the way we typically screen for adrenal problems, cortisol is what's called a diurnal hormone, meaning its levels vary by time of day. And the highest level is around at 8 o'clock in the morning. So we usually have folks get a non-fasting cortisol level. We measure the ACTH as well. ACTH, going back, is this pituitary hormone that leads to the production of cortisol. Excuse me. And we see, kind of where day to day does that do those hormones live? And that initial assessment sometimes gives us an answer as to whether or not production is sufficient or insufficient. We also measure a hormone called renin, aldosterone, and DHEAS. And those are other hormones made by the adrenal gland. So the hormone I'm telling you about, cortisol, is a glucocorticoid. It's made in this region. This is a schematic of the adrenal cortex. Cortisol is made by this particular part of the adrenal gland. Some folks have deficiency of only cortisol because they have a deficiency of how that signaling happens from the brain. Some folks have deficiencies of all hormones produced in the adrenal cortex because something has happened to the gland itself. So that might include the mineralocorticoid hormones. That's the aldosterone, which helps control fluid balance and prevent dehydration. The androgens, so hormones with male-like effects, that's what DHEAS is an androgen hormone. So if we suspect that more than one hormone is affected, we might measure those other hormones as well. We do something called provocative testing sometimes for folks in whom we suspect adrenal insufficiency. So the tricky part about hormonal testing is that sometimes certain hormones are only produced in times of stress. And if we check folks when they're feeling good, well, then we see what a cortisol level might be when they're feeling healthy or typical, which may or may not be as informative. So we bring people into day medicine at our hospital, we bring them and we give them a dose of ACTH. We give them a dose of the pituitary hormone that typically leads to a cortisol response in a healthy gland. And we see, can they mount that increased response when the pituitary tells them to? So that's how we can get some additional information in folks in whom we might need it. And then if we decide someone has adrenal insufficiency, we have to have clarity around, okay, well, do they need just this cortisol replacement? Do we need just hydrocortisone or prednisone to replace glucocorticoid? Or do they also need mineralocorticoid replacement? That's Florinef, fludrocortisone. we need some amount of steroid every day when we're feeling good, when or ourselves, and then what's called stress dose steroids, meaning higher doses of steroid when a person is encountering a stress. So we need a regimen that accounts for both. And we also need a regimen that accounts for both when someone might not be able to take medicines by mouth or by G-tube. If they're vomiting, for example, how are we going to deliver those steroids? So our emergency letter for folks with adrenal insufficiency is pretty involved. I'll mention the iatrogenic Cushing's, or the adverse effects of steroids. So one of the most common reasons for adrenal insufficiency in all patients is folks who've gotten steroids for other reasons, for example, asthma or breathing problems, at very high doses for some time, and the person's own adrenal gland gets quiet because it hasn't had to work very hard for so long. So steroids can have side effects too, one of which is this iatrogenic, meaning the effect of the therapy on the adrenal gland, but also problems with blood sugar, problems with bone health, with mood. So too much steroid is not great either. So we have to be really thoughtful in making this decision, in making this diagnosis to make sure it's appropriate, and in making our therapeutic decisions to make sure we're not doing more harm than good. Who needs testing? This is a great question. I am showing you this this table from a paper that was led by Todd Kilba, one of our colleagues at CHOP. Mainly, it's showing the increased rates of mortality for children diagnosed with mitochondrial disease in the PICU. And the reason this table is relevant to me is because this idea of like how well a child responds to critical illness, how well they respond to stress, it just resonates that it's important to make this diagnosis, or to consider this diagnosis, because maybe it's one of the factors that it influences things like ICU outcomes. So we certainly consider testing anyone who's received high dose steroid medicine, for example, like weeks of steroid for asthma, individuals with suggestive symptoms, things like low blood sugar or unexplained low blood pressure. And in some individuals who are critically ill, they get empiric steroids in the ICU in case the adrenal insufficiency is contributing to their picture. So this is switching gears again. So we've talked about adrenal insufficiency. Another hormonal deficiency that can impact blood sugar is, believe it or not, growth hormone. So one question that we come up with, going back to this patient I introduced you to at the beginning of the talk, at the time when we're evaluating someone for short stature, is does this individual have growth hormone deficiency? Because growth hormone is not only important for growth, but it has other metabolic effects too. So growth hormone is one of the many hormones that's part of our counter-regulatory response, meaning how our body defends itself in times of stress. Growth hormone brings blood sugar up. When we take care of neonates who have profound growth hormone deficiency, they can present with low blood sugar. Less common to have that happen in an 8-year-old, for example, but certainly growth hormone can contribute to blood sugar in either direction. So, you know, when I'm asked about growth and growth deficits and mitochondrial disorders, there's a reason I think that impaired growth affects so many of the folks with mitochondrial problems, is because growth requires energy. And, you know, one of our senior clinical colleagues, you know, says, the way she says it is, she frames it, is that growth is a luxury, right? So if there's plenty of nutrition around, and a child's body senses that it's the right time to grow and develop the capacity to reproduce, then it will do that. But a child who's chronically ill or inadequately nourished won't grow, because it can be more difficult to sustain health in that setting. So I think that's why growth impairment is so widespread in children with chronic diseases of all kinds, mitochondrial diseases especially. Impaired growth can also be the presentation of mitochondrial disease. And this, you know, we present this to colleagues in endocrine specialties, they know, so mitochondrial disease can be so protean, so many different manifestations. Like, how do they know they're not missing someone when they're evaluated for short stature? And the answer is, it can be kind of tough to know if they're not missing. It really takes a careful evaluation. So this is an example from the literature, an 11-year-old who had presented for evaluation. This is their growth chart. You can see, similar to my other patient, right, who had been kind of tracking along and then fell off, and by 11 was evaluated for growth failure that happened after they were born. So they were born at a typical size, and then fell off, and the child also had fatigue, low thyroid function, and eye findings that you can see and recognize probably as ptosis. So this individual importantly had reasonably well maintained body mass index, although sometimes nutrition is the big culprit. So question often comes up, what is the cause and what can be done here? We've done some statistical modeling in our patients with mitochondrial disease, the healthy as compared to healthy reference cohort, which is shown in red, that individuals with mitochondrial disorders, either girls or boys, shown in blue, tend to be shorter on average than the healthy reference. And this height discrepancy often becomes most apparent at the time of the pubertal growth spurt, because that pubertal growth spurt really requires a lot of extra energy, and it can be difficult for folks with mitochondrial disorders to sustain that growth spurt. With respect to the causes, I alluded to some of them. Sometimes malnutrition or GI problems contributes the way it does in any condition. So these are data from CHOP showing BMI, Z-score. Z-score is kind of how robust is the body mass index, or how robust is the height. With different subtypes of mitochondrial disorders, different subtypes, including the deletion. Folks with deletions may be the most impacted height-wise. It's not uniformly true. I think our colleagues are very sensitized to making sure that kids are adequately nourished. So while it's important to make sure that malnutrition isn't the cause, certainly it's not enough to nourish the child adequately and to expect that they will necessarily grow. We also look, of course, for thyroid problems, for sex steroid problems, growth hormone deficiency, to see if any of those might be contributing to poor growth. And then we must also wonder, could this be a child adapting to a bioenergetic defect by staying smaller? And I suspect that may well be true. The decision to treat with growth hormone is a complicated and individualized one. And we spend a lot of time in our clinic having thoughtful discussions with families about this. The factors to take into consideration, the short stature, how short is the child, and how much is that impairing their function? How much has the growth velocity slowed? Is low blood sugar a consideration? Is fatigue a consideration? Because growth hormone can impact energy. How about decreased muscle mass, decreased bone density? Those are other things that can be affected by growth hormone deficiency. How well have we excluded other causes? What are our growth factors? So insulin-like growth factor 1 and IGF-BP3, those are two growth factors that are affected by growth hormone. In general, the more profound the deficiency and the more significant the growth hormone deficiency, either by growth factors or provocative testing, the more likely a child is to respond to replacement. Growth factors can also be low in the setting of malnutrition, so it's also important to keep in mind. GDF-15 is a hormone that you may be familiar with. I find in some mitochondrial disorders that value is very increased. It's abnormal, in particular mitochondrial DNA deletion. In others, it's not. But when it's higher, it's often associated with short stature that in my clinical experience may or may not respond very well to growth hormone. So I think we talk with families about potential growth benefits, also potential non-growth benefits of growth hormone, and what dosing we might use, because we can see some of the non-growth benefits at what we call adult growth hormone dosing versus pediatric dosing, and see, did those benefits weigh favorably against the potential downsides of growth hormone. And there are two that I highlight most. One is diabetes, because growth hormone increases blood sugars and challenges the pancreas. So I think it can unmask diabetes in folks who are vulnerable and lead to a sooner insulin requirement. And I've seen that happen. And risk benefit for many families, that's something they may wish to avoid. Also, a kind of more theoretical consideration, but one that I think is valid, is that if there's a child whose body is staying smaller because growth may kind of stress the system, then is administering more of that growth hormone just going to produce more stress, and will the child's body have difficulty keeping up? I think that's more of a theoretical risk, but an important discussion and consideration. So what we make sure that we use kind of shared decision making and speaking with families to balance these considerations, and then if the decision is made to treat or to watch and wait, to continue to revisit that decision at intervals to see what makes sense to do. So I hope I've persuaded you that endocrine disorders are prevalent in individuals with mitochondrial problems, and that there's some evidence supported ways to screen and to treat these problems in ways that are helpful for families. So I'm gonna stop there. I've been really excited because we're now like at double digits on the Q&A. That's awesome. That means we have some nice opportunities for discussion.
Absolutely. Thank you so much. I feel like my brain is like bursting. I've learned so much through your presentation, and there have been some really great questions that have
And
filtered
I was gonna say, I'm
in.
fine to go a little past 2. I'm mindful of the time, but if people want to stay on to answer their questions.
Okay, perfect. So first question, it says with exercise, some people with mito have atypical reactions to exercise. Maybe a female who's trying to lose weight tries HIIT intervals and she gains weight instead of loses weight, or blood sugars can crash the next day. Exercise seems, well, then she asks, how do you tell your patients how to exercise and the dangers to watch out for metabolically?
Oh, actually, well, this is a great question. The first compliment to the person asking, because exercise is so important for so many reasons, and folks with mitochondrial disorders to help maintain function, help with mood, help with muscle strength, help with metabolic response, like all of that. So how do I tell folks how to exercise? It is very individualized. I mean, because, for example, some of our folks have heart problems, some of our folks have diabetes. So we are lucky where we are to collaborate with some terrific cardiologists and physical therapists. So if you have someone where you are who can help assess where is your fitness currently and where does it need to be, to get an individualized regimen, that's helpful. I think a lot of people who are enthused go from 0 to 60, like get really excited and go really quickly. And that tends not to work with anyone, especially in folks with mitochondrial disease. There is some amount of learning, trial and error. It sounds like, unfortunately, this person who's doing amazing and trying, but to learn about how the person's body responds. I think that something that's underutilized, getting people ready for more cardio type exercises, strength training, because I think training the muscles first so they can be strong and withstand or generate a good aerobic stimulus, I think is really helpful. Like that does require a lot of education, like more than walking or riding a bike, some of the cardio activities that people may enjoy. But I think strength training is really helpful. So, I mean, all my patients are different with respect to, we actually in our Friedreich ataxia cohort are doing an in-home exercise, and in one cancer survivor cohort, an in-home exercise trial now, but that exercise is individualized and gets adapted and monitored by physiologists. So bringing up this question with either cardiologist or metabolic doctor and thinking about like what would be a schedule to try, what are the factors, how do we nurse the person and hydrate the person before, how do they recover, what's the right interval, how do we follow them along and adapt if they develop symptoms, I think all really important.
So it sounds like that it's really important to have kind of coordination of care between maybe their endocrine, doctor or cardiologist and their PT. So everybody's kind of working together as they're trying things out and figuring it out individually.
Especially thinking about like, well, if the person has diabetes, right? Like if you exercise in such a way that then your blood sugar gets low, well, then you have to eat more to make up for that. And then you may struggle with weight gain. So we adapt an insulin regimen for sure.
Okay.
If someone's going to be exercising.
So can you speak a little bit more about weight gain with the diabetes? I mean, I know that's a broad topic, so maybe that's another presentation another time too, but maybe there's if there's a few more tidbits you can add about that.
About weight gain. Yeah. Well, for folks who have diabetes in the context of excess weight gain, they may be familiar with the glucagon-like receptor peptide agonist, the GLP-1 agonist. Those are medicines that can help with weight loss and can help with blood sugar control. For folks with diabetes or with mitochondrial disorders, it's really relevant that there are GI type side effects like nausea and early satiety that are really difficult to manage, and there can be a risk of pancreatitis. So we don't use those agents lightly, but we do offer them and use them. And I sometimes start instead of escalating the usual way, like start those agents in folks who are trying to see weight loss, like very, very low. We screen with pancreatic function tests first and we screen throughout, so that might be, discreetly there's an option. we know in folks with mitochondrial disorders, like the exercise intolerance can lead to less activity, which can exacerbate weight gain. So really, another plug for exercise and PT to help folks along the way.
For teens with central adrenal insufficiency and mito, so they can use sugars but not fat to make energy, how exactly do you determine a definite hypoglycemia diagnosis, and how do you treat it, especially if they're seeing crashes like falling asleep, severe fatigue?
Yeah, that sounds really hard for for folks who are experiencing that. I mean, I think we start with how the blood sugars are being measured. So if there's we do frequent monitoring during the diagnostic phase to see, are there blood sugar correlates of these crashes, like either right before, right after, or during, and then are there ways to modify the way the adrenal insufficiency doses are timed, like with time of day, or sometimes even with, relative to activity or meals that might help avoid those issues. It sounds like a really hard problem.
Are there studies that link mito with lipodystrophy? And did I say that correctly?
Yeah, with lipodystrophy there are. So for folks who aren't familiar, lipodystrophy means like abnormal formation of fat. So people, and when excess weight gain is a concern, but like too little fat or fat in the wrong place is also a problem. There are certain subtypes of mitochondrial disorders in particular that are associated with accumulation of fat in the wrong location, or fat that doesn't function well. So to the person who asked, there are.
So where is fat accumulation typically for?
It depends. There's some subtypes
Okay.
where there's like patches of like, there can be lipomas, like growths of fat tissue. And then there are some forms where like the fat just doesn't function in a typical way, if that makes sense.
No, it does. That's really helpful, really helpful. Another patient says, I don't have a genetically confirmed diagnosis of mito yet. I have been having increased endocrine issues. I don't know why I always have trouble with that word, endocrine issues. And in January, I got diagnosed with T1DM and Hashimoto's, positive GAD65, not on anything due to not high enough BG or A1C. Do you feel like that's more consistent with mitochondrial diabetes or type 1 diabetes?
Yeah, so that sounds challenging as well. So for folks, Hashimoto's is an autoimmune form of thyroid problem, and GAD65 is one of the, we check 4 different anti-pancreatic antibodies when we're diagnosing someone with diabetes. So there are some folks with mitochondrial disease who have autoimmunity, along with their endocrinopathy, but generally the kind of flavor of mitochondrial diabetes is to be autoimmune negative. So this person either has kind of a hybrid, or at least at this point seems to have a more autoimmune presentation.
Okay. So since mito, so with mito, if you're more prone to diabetes, how does COVID play into the complications of that? Are you more at risk for serious COVID complications due to that? Or is there any literature out there on that yet? Or
what a great question. So Peter McGuire at NIH, if folks aren't familiar with his study, and I think he has a natural history study for which people may be eligible to volunteer. He studies immune function in mitochondrial disorders. Just fascinating, because I as I recall, he's studying kind of COVID and other infections and how they, I don't know if he's studying COVID in particular, but I know for sure like infections and vulnerability. The diabetes connection to COVID, I'm not aware of studies in mito. I am aware of studies in Friedreich. So we know our patients Friedreich ataxia, which genetic disorder that affects mitochondria as well. And for sure, diabetes is one of the biggest risk factors for COVID complications. So I would suspect that folks with mitochondrial disease and diabetes would be at more risk for COVID complications, the way anyone with diabetes seems to be disproportionately.
are sugar ranges the same for adults and pediatrics?
Yeah, in mitochondrial disorders, I think the target blood sugars are usually individualized. So in general, for children, we sometimes tolerate higher blood sugars than in adults, but not always. It somewhat depends on how well can they communicate symptoms, how vulnerable are they to lows, do they have seizure disorder? But if someone has a continuous glucose monitor and they're monitored very carefully, then we can sometimes have a reasonable blood sugar range in both. In much older adults, we tend to tolerate higher blood sugars as well because the downsides of lows are more substantial, but it's usually individualized.
So this question says hydrocortisone versus prednisone for central adrenal insufficiency. Why one versus the other?
Oh, I love that question. Hydrocortisone usually has to be given twice a day, prednisone once a day. Prednisone has a longer half-life. So I tend to favor hydrocortisone because you can give, which is what I typically start with in most patients, a higher dose in the morning and a more moderate dose early to mid-afternoon to try to recapitulate the cortisol daily rhythms. That said, everyone's dosing is different. We sometimes use prednisone if you have often, our adolescents or young adults who are like, I am just not taking a medicine twice a day and I need that afternoon dose. So that might be a reason to choose. But the difference in half-life and the ability to kind of titrate by time of day and convenience, like those are some of the factors.
So you mentioned the correlation between patients that have deletions and the connection between the diabetes. And this person is asking about how deletions are recognized. I assume through genetic testing.
That's genetic testing. Yep. So the mitochondrial DNA, you saw the circle diagram, like you can see if our genetic colleagues who run the test can see if a chunk of DNA is missing.
This patient asked, should I be getting, and I might not get this correctly, hype download test? I'm on Trulicity and Tujo. Should all with mito and diabetes have anti-pancreatic autoantibody tests?
Oh, good question. So I also didn't quite understand the first one, but like, should I be evaluated for low blood sugars? Like certainly anyone who's on a glucose lowering therapy, like Toujeo, like a long acting insulin, should be mindful of potential lows. And then I think everyone with mitochondrial diabetes who has, or mitochondrial disorders who has diabetes deserves anti-pancreatic autoantibody testing, mainly because it helps us understand more. If you have 4 out of 4 antibodies positive, you have a lot of autoimmunity that suggests you're going to need even more insulin over time. One thing to remember is if you have autoantibody testing after you've already had insulin, you may have an anti-insulin antibody. That's one of the kinds of antibodies, but that's potentially related to the treatment that's already been received. So something to discuss with your physician for sure, like, hey, would it be helpful to have this additional information? And your clinician say, well, I suspect it's going to be negative and it won't change my management. You're like, well, that's great. So if it's negative, then it's negative and we're done. So we tend to get it, at CHOP in all pediatric patients. On the adult side, that probably wouldn't be practical given, like 37 million, but for folks who also carry mitochondrial disorder diagnosis, probably not unreasonable to understand a little better.
So this kind of goes in, that question kind of ties in with this other question and a further question, which is, first of all, like with cortisol tests, should that be done fasting or non-fasting? Does that change results? And then also just recognizing your expertise on mito and diabetes, like how do you go about finding a you if you don't live in, like in Pennsylvania, or like, how do you know, like, are there certain boxes that should be checked, like when you're talking with your doctor about diabetes, to make sure that if they don't understand mito quite as well, that they're still, checking the boxes that they should with your care with diabetes?
That's so great questions. Okay. So the first, I think you talked about cortisol and should it be fasting. So safety first. If we do not, for outpatient testing, I never recommend that somebody fast longer than what we say their usual fasting interval is, right? So if you like have dinner and bedtime snack at 8 and then, you eat breakfast at 7, then you get your labs and you should not exceed your fasting time typically. The 8 a.m. cortisol that we usually get as a starting place, you do not need to be fasting for that. That's a time of day dependent hormonal test that does not require fasting. The provocative testing, and that's because we're just trying to assess your usual daily rhythm. And if it's a time you would usually have eaten, then you should eat. But the provocative testing is a little different. It's designed to produce a stress. We sometimes have people not eat a ton. It doesn't have to be a fasting test, but we often have them not eat a ton before that because we think the response will be more robust. But that test, and also because sometimes they stressed or vomit during it, but that test happens in a hospital under supervision. So we feel a little more comfortable challenging a little bit more. And then you asked about like identifying folks with expertise. Mito Action, like UMDF, Mitochondrial Medicine Society, like there's lots of organizations that have links to resources for curious patients and clinicians. And in my experience, like finding a doctor who is interested, curious, because even within mitochondrial diabetes, like different patients are different. So having a doctor who is willing to take the time and learn about you and spend time with you is probably even, and it's convenient to go to, because for diabetes, you do have to go pretty often, is the most important thing. If you can find such a person. We at CHOP for Kids, and perhaps some of our adult colleagues are willing to do this too. We sometimes see folks like once a year to say, hey, how's it going? Like, can we be a second set of eyes to support your local team and collaborate together? And we always are happy to field calls from local clinicians. Usually we don't give guidance. We don't give guidance directly to patients who are not our own, just because we wouldn't have the context. We wouldn't want to miss anything or misinform folks. But if we have another clinician who says, hey, gee, I'm thinking about starting this medicine, like, what do you think? Or what's your experience? So we always learn so much from those interactions. So I know that's a tall order, especially on the adult side of like finding someone. Hopefully being in an academic center or a bigger center, you have more folks who might be flexible with their time or more curious to kind of go to take the extra initiative to learn and be curious. I realize not the easiest answer.
No, but it's super helpful. And I think it's helpful to point out that, although you can't give patient advice if they're not your patients, but like the clinicians can call you and you guys talk to each other, because sometimes, I think you feel alone on an island and you worry for your clinician because, they know what they know. And but that, that's the power of connecting, and networking with other clinicians.
And we do it. I was just on service this weekend and I called like several colleagues with, cases that I've seen a lot because, as you say, no one should be an island.
Yeah. Yeah. Well, there's some more questions. Maybe I can send some of them to you via email, and I can make sure that those patients, get those questions answered. So if you didn't have your question answered and you want to email me your question at sharry, HARRY @mitoaction.org, I will try to make sure that we get some of those answers sent to you guys as soon as possible. And it was just amazing. It was amazing having you here. I really, really appreciate your time and breaking all of this down for us. And, it's a huge topic. And I know it's such an important one for our community. And one of the things I love about this Zoom, somebody asked, is this going to be recorded? This is absolutely recorded. And so the lovely thing about that is that you can go back and view it again because it's a lot of information to absorb at one time. And so I hope that when we get this posted on Google Play and Spotify, also on our website, feel free to go back, take a look. And if you have questions, come to support group or ask those questions of your doctor. It's really important and helpful. So thank you so much, Dr.
Oh my goodness, I learned, and I know, I'm sorry we didn't get to all of them. I love giving this talk and I love these questions, and it's amazing that you're these folks. I know some of it you have to be so well informed because you have to be good advocates, and that might feel stressful, but hopefully leads to good conversations with your clinicians and get some good ideas or options for people to take back. So this was really fun. Thank you for letting me learn from you.
Absolutely. Absolutely. Have a wonderful day.
Thank you. Take care.
Bye.
Bye.